TSH, T3, T4. I need you to remember this easily. If you find both of them high, TSH, T3, T4, you find both of them high, what are you going to think about?
Hyperthyroidism.
Mm-hmm. We are speaking about primary and secondary, so it's going to be a secondary cause.
If
It's
all of
hyperthyroidism, but yeah, we're speaking about hyper.
mm-hmm.
But you're speaking about, is it secondary or is it a primary hyperthyroidism?
Okay.
So if you find both of them on the same direction, you're gonna say it is
Secondary.
Secondary.
secondary. If you find the T3 and T4 high, but you find your TSH is going down, what it is?
Primary.
This is gonna be primary. So if you find the TSH and T3, T4 on the same direction up, it's gonna be secondary. If you find the TSH is low, this is telling you that there is maybe a feedback, it's working, maybe the problem is coming from the thyroid itself. Because here both of them up, sorry, this is telling you that maybe there is a problem outside of the thyroid, that's why TSH and both of them is high. There is no negative feedback. So next point. Let's finish secondary because it's easy. If you're thinking about secondary, this next point is going to be for us here, clinical features. If we're speaking about secondary for the clinical features, I need you to remember three things. One, I need you to remember headache plus visual disturbances. Number two, I need you to remember amenorrhea. Amenorrhea, and because of what? Why do you think amenorrhea is going to happen here?
Because of TSH is related with prolactin.
Hmm.
So there will be the inhibitory effect on LH and FSH. So will lead to amenorrhea.
So is it happening because of the thyroid? Is it happening because of what?
Hyperactive.
Yeah, it will occur in
Because of the pituitary, I think, and the FSH and LH are going to be high, so that's going to be a negative feedback on the ovaries and for the menstrual cycle, and that's
Mm-hmm.
amenorrhea, cause amenorrhea. There's not
Oh,
going to be ovulation and
okay, okay. So there is 2 points here. There is 2 points here. First point, please write it down so you can remember it. Amenorrhea. Why we are speaking about this? When you are speaking about secondary, you are speaking about maybe something happening to the pituitary, yes? So if you have a pituitary adenoma, if you have a pituitary adenoma, what's going to happen to LH and FSH?
high.
Hmm. Is it going to be high or it's going to be low?
high. And pituitary adenoma, they will be high. Hi.
When the prolactin is high, so there is hypersecretion of all the um, on the anterior pitot.
Adenoma, that is due to the prolactinoma.
Yeah, so
Yes, but we are now speaking about pituitary adenoma. Will you find LH and FSH high or low? What do you think? We're not speaking about the prolactin now.
mm,
prolactin will have the negative feedback effect on LH.
Pituitary adenoma causes hypogonadotropic hypogonadism.
Okay.
So what do you think, Dr. Stephanie?
Yeah, low. I don't know why I was thinking that they will cause, like, I guess because I was
Yeah, I think that you're thinking it's high because it's adenoma and pressuring.
yes. Okay.
It's okay. So you're gonna have impaired of the normal secretion of LH. Please concentrate. This is very important. Plus FSH. If you have both of them going down, what's gonna happen to the ovulation?
No,
Ovulation.
no,
Will you
Yeah.
have ovulation or less ovulation, or what's gonna happen?
Yeah,
less
no.
ovulation. No, no
Ovulation,
ovulation.
it's gonna be decreased, or you won't have ovulation. Why we are saying decrease? Because here you could find allegoria or amenorrhea. Because of the pituitary adenoma, you're gonna have FSH and LH low. If you're thinking about FSH and LH low, you're gonna think about ovulation decreasing. If you have decreased or less ovulation, you're gonna go ahead and think about oligoria or amenorrhea. So here we said that we're gonna have headache, we're gonna have visual disturbances. We're gonna have amenorrhea, and you did find out why it's amenorrhea, but on the same time, your pituitary adenoma can cause for us hyperprolactinemia. Did you get it all?
Yes.
Yeah.
Yeah.
So please concentrate because someone gonna repeat all what we're speaking about right now. Next. Next, we're gonna speak about autoimmune markers. So if you have TSH and FSH on the same direction, you are thinking about it's a central cause or secondary, SC maybe, or SS, just remember central, secondary. If you are thinking about the clinical features, you're gonna find headache, visual disturbances, and you're gonna find amenorrhea or hyperprolactinemia. If you are thinking about autoimmune markers, you will find no or none here. Last point. The last point, it's gonna be here radio iodine uptake. Radio iodine uptake, what's gonna happen to it for if we're speaking about the secondary or the central? It is gonna be increased.
Diffuse uptake.
It's gonna be increased. The uptake is gonna be increased. Just remember this for now. So I'm gonna recap it again and then we're gonna go for the primary. Please understand it and keep it in your head. Please try to memorize it. When I'm repeating it, try to repeat what I'm saying in your head. So if we're speaking about secondary, you're gonna look for TSH and T3 and T4. If you find the three of them on one direction up, you're gonna think about it is a secondary or central cause. If they're asking you about the clinical features or you're looking for the clinical features, that's when you're gonna find that there is a headache, there is visual disturbances, and the most important for you is amenorrhea and hyperprolactinemia. If you're looking for autoimmune antibodies, here you will find none, nothing. It's a general picture. You cannot take just one point from here and say, I'm going to look for the secondary. No, you need to have the general picture. Radio iodine uptake, you're going to find it increase with the secondary. Next. If we're speaking about primary, we said that your TSH is going to be low because the problem is not up, the problem is down in the thyroid. Clinical features, very important. If you find ophthalmopathy, what it is?
Graves.
You're going to think about Graves. Yes, you're going to think about Graves. If you are thinking about tender goiter, what are you going to think about?
Thyroiditis, subacute thyroiditis.
So there is two other things here. It's
Tender means inflammation.
yeah, so tender goiter, or you're speaking about painless goiter. Painless goiter. If you're speaking about painless goiter, what is your differentials? It's either silent or
Subacute.
we're speaking about the postpartum mainly thyroiditis. Yes, I need you to remember for me silent and postpartum.
Is it also called subacute? Is the same thing?
We're gonna go for it now. Just give
Okay.
me one moment, we're gonna go for the subacute. So if we're speaking about tender goiter, what is sorry, the SGT? Come on, doctor. You just said it.
Subacute thyroiditis.
It's sub. That's what he was asking about. Subacute thyroiditis. So you're gonna look for if there is eye symptoms, you're gonna think about Graves. If you are thinking about your tender goiter, you're gonna think about SGT, or you're gonna think about the painless goiter. Why we didn't include it with the painless goiter, guys?
Sorry, which one?
Subacute.
It's tender, so it's painful.
Painful.
It's tender. That's why you're gonna remember for me here, it's not painless, it is painful. What is the other name of this decurvent thyroiditis? It's painful.
SCT stands for?
Did you see it, guys? Yeah. Sorry, say again.
SCT means
It's
stands
G.
for?
SGT.
Okay, SGT.
SGT, it's subacute granulomatous thyroiditis. Did you get it?
Yes.
Thank you so much. So for primary, you're going to look for TSH and T3 and T4. If you find them in opposite directions, you're going to think about, I'm going to look for it. Is it painful? Is it painless? Painful, your answer is going to be subacute. Painless, you're going to think about the silent, you're going to think about the postpartum. How about Hashimoto's?
It's also painless.
How about Hashimoto's? What do you think?
It's
Is it
autoimmune.
painful or painless?
Painless.
It is autoimmune painless.
Painless.
Almost all are painless except the subacute one.
Subacute, it's painful. But will you add Hashimoto's to the list of the painless?
Okay.
So here we're gonna think about silent, postpartum, and Hashimoto's. The next question. Who's gonna take it? Who's gonna take the next question, guys?
I can try, doctor.
Okay, Dr. Stephanie. Hashimoto, from which country he is?
From Japan.
Come on, guys, try Hashimoto.
Yes, it's Japan.
What do you think? Only Dr. Stephanie here today. Where's the rest?
Yeah.
Japan, yes.
Japan, are you sure?
Doc.
Yes.
Okay, guys, I'm not gonna just. Okay. So, okay, the next point. The next point, we spoke about the autoimmune markers. With the central or the secondary, we said none. Very nice. Easy. Here, your life is going to be easy too. I need you to remember that you're going to find TRAB or TSI. TRAB or TSI. Once you find them, what you're going to think about?
Hashimoto.
Grapes.
Graves.
It is Graves.
Thyroid receptor.
Mhm.
Okay.
What's AM?
Abdullah Mustafa.
Autoimmune.
Autoimmune markers.
Autoimmune marker. Okay.
God.
So AM. Yeah, I did attach for you a detailed chart. It's something similar to what we are doing now, but I did add for you more information to it. And I created for you as a table, and I added for you to the new capsule, which you're going to receive it soon. So, but I need you now to write this in your notes because I'm going to check about your notes as usual. So, if you find your TRAB and TSI, you're going to think about Graves. If you find TPO, you're going to think about
Hashimoto.
not only Hashimoto's, you're going to think about the whole team.
Yes.
Hashimoto, you're going to think about silent, you're
Silent.
going to think about
Postpartum thyroid.
postpartum. Postpartum.
So basically
Easy.
thyroiditis.
Yeah.
Apart from the Quivian.
TPO, we are speaking about. What we are speaking about?
Thyroid
Thyroid
peroxidase.
Thyroid peroxidase.
It's thyroid peroxidase antibodies. TRAB, what it is?
Thyroid releasing and thyroid receptor antibody.
Thyrotropin
Thyrotropin
receptor
receptor.
antibody.
Yeah.
Yes.
So it's a thyrotropin receptor antibody. TSI, what it is?
Thyroid stimulating immunoglobulin.
Immunoglobulin. You need to have them written down. I did add it to you in the capsule, but you need to write it down now. The last point. Easy. The radio uptake, we said with the secondary, it's going to be always increased. If we are speaking about your primary, what's gonna happen to the uptake? It's either gonna be the same thing, but here it's gonna be up. It's either gonna be up or it's gonna be down. Okay. So I need you to remember the next. Either it's gonna, either it's gonna be down or it's gonna be up. If it's going down, you are thinking about less activities. So you are thinking about your silent, postpartum, and so on. If it's going up, what are you gonna think about?
Increase activity.
So you're gonna think about Graves.
Right.
You're gonna think about toxic adenoma, and so on. Let's recap the whole table. It's either primary or secondary. You're gonna look for TSH and T3, T4. If both of them on the same direction, it's gonna be secondary.
Secondary.
Yes, secondary. If both of them is in a different directions, you're gonna think about
Primary.
primary. If you are thinking about the clinical features for the secondary or the central, you're gonna find
Headaches and visual disturbances.
Headache,
and
visual disturbance,
and
Amenorrhea or
Amenorrhea.
and
Hyperprolactinemia.
and we spoke about why we find amenorrhea. You need to remember it, please.
yes.
So clinical features we spoke about. If you find eye or ophthalmopathy, what you're gonna think about?
Graves.
Grave disease,
Graves, if you think that it's painful.
Decurvant or
Decrevent or subacute thyroiditis.
No.
Subacute.
Dr. Henry, we are speaking about painless. Is subacute painless?
Oh
No,
no.
you said painful.
Painless is silent postpartum.
Doc, you said pain. You said
But
painful.
you said
Doc.
painful.
You said painful.
Wake up.
Wake up.
No, then someone said something else. Someone said something else then. Okay, if it's painful, what it is?
yeah, that's the
Subacute.
It
Subacute.
is
Subacute thyroiditis.
it's subacute, and if it's
Yeah.
painless,
Yes,
Like
you have silent
silent
thyroiditis,
postpartum
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 thyroiditis,
thyroiditis.
Hashimoto
yes. If
thyroiditis.
you find TRO antibodies, what it is?
TRO is
TRO.
Graves. TRO or
Is it
TPO.
TPO?
TPO, sorry.
TPO,
is
heck, Hashimoto.
Hashimoto,
Yeah.
silent and
Silent and
postpartum
postpartum.
Possible silent postpartum.
Yes, TPO.
painless ones.
Or if you find the TR antibodies, what is the TR antibodies?
Thyroid
Thyroid
receptor
receptor
antibody.
antibody.
Yeah,
antibody.
Yeah. So what
That's
is the
Graves.
TSI?
Thyroid stimulating
Stimulating
immunoglobulin.
If you
Immunoglobulin.
find both of them, what you're gonna think about?
Graves disease.
Grave disease.
Graves. So okay.
For the optic,
Optic what?
radioiodine optic.
Oh yeah. So the radioiodine uptake, if you find it low, you're gonna think at low activity, you're gonna think about
All the thyroiditis.
Graves.
yes, silent, postpartum, and so on. If it's low, we are speaking low.
Yes.
So once you draw your table, you're gonna find that you have an arrow down and arrow up. You come down, you make the same thing. Arrow down, arrow up. So that's the first table. I'm gonna ask someone to repeat it, but not now, just shortly. So next, it's
Doctor, what is TA in radioiodine uptake?
Toxic adenoma.
toxic adenoma. It's Graves and toxic adenoma.
Okay, thank you.
So next is very important. It's the same thing which we did, but we're gonna apply it on how you're gonna evaluate the patient with hyperthyroidism.
Yes, sir.
If you have a patient with hyperthyroidism, how are you gonna start to evaluate this guy? You're gonna go ahead and measure
TSH
TSH and
and T4.
T4.
T3, T4. After you do this, you're gonna have two options. One, and you're gonna have two. One, we said it's gonna be if you find that TSH is low and T3, T4 is high, what are you gonna think about? Which problem?
Primary.
Primary.
It is primary. If you are thinking about both of them up, both of them high,
Secondary.
Secondary.
that's gonna tell you it's secondary. Once you think about its secondary, we spoke about the clinical features, we spoke about the radio iodine or the iodine uptake, we spoke about the autoimmune bodies. Please, someone, okay, Dr. Stephanie, tell me what you're going to find on the secondary. Tell me everything from the table.
So on the secondary, we will find TSH and T3, T4. They are both going to be elevated.
Mm-hmm.
Clinical features, we're going to have visual disturbances and headache,
Mm-hmm.
and also amenorrhea with hyperprolactinemia. For the autoimmune antibodies, we're not going to have autoimmune antibodies, and the reuptake is going to be increased.
That's very nice. So once you find all that, Dr. Stephanie, here is the question. What is the best next step for you?
So that will be MRI.
It's going to be MRI where? Hip?
Of the head.
Which
MRI.
part? So you are trying to target the pituitary.
Yeah, the pituitary.
Pituitary gland. That's the best next step for you. The next best step for you in this side here. It's gonna be after you find them in different direction, you think about primary. The easiest for you. You're gonna ask yourself, do I have symptoms of G goiter or O ophthalmopathy? If your answer here if your answer is yes, or let me just clear this. I'll make it for you like this. If your answer here is yes, what you gonna say? What it is?
It's Graves.
It is Graves. If your answer is coming here and you say no, there is no goiter or ophthalmopathy, what is your answer? You're gonna go here and do the next step. So first of all, you did measure the TSH and T3, T4. You did look for the clinical signs. Now you don't find any of them. Your answer is no. Now you are trying to locate or scan where is the problem. How you gonna do this? You're gonna do Dr. Henry's favorite test. It is radioactive iodine uptake. When you are doing your radioactive iodine uptake, you have two things could happen here, as usual. One,
Increased or decreased?
yes. First one, it's either it's gonna be high or low. So you're gonna do your radioiodine uptake. If it's low, you know the answer. What it is.
Awesome.
If it's low, you're gonna think about thyroiditis or whatever it is. Yes, so you're gonna think about the thyroiditis. But after you find it low, what else you could do here? You can measure the serum thyroglobulin. After you measure your serum thyroglobulin, you have two things here. Please concentrate, we're gonna recap it all. The same thing, either high or low. If you find the serum thyroglobulin high, what are you gonna think about? Thyroiditis. Or iodine exposure. Again, this point because it's very important. If you have your radioactive iodine and you find it low, as we said on the top, it's gonna be low in your thyroiditis. You suspect thyroiditis, but sometimes they come down to ask you about something else. They come down to ask you, what is the best next step for you? So you're gonna measure serum thyroglobulin. Thyroglobulin, you are doing it here. You're gonna make for me a small arrow in your notes and you're gonna write down why we do it. To help to distinguish between endogenous thyroid hormone from the exogenous thyroid hormone use. Thyroglobulin is made by the thyroid gland. So if the thyroid hormone in the blood coming from the patient's own thyroid tissue, what's gonna happen to the thyroglobulin, guys?
To be high.
It's gonna be high. That's why you are seeing thyroiditis. If your thyroglobulin is not, if the patient does not have, if the thyroid hormone is coming from outside of the body, if the thyroid hormone is coming outside of the body, maybe you are speaking about pills. What's gonna happen to the thyroglobulin?
To be low.
It's gonna be low. That's why we said if it's low, you're gonna go down and think about exogenous hormone. In this point, because it's exogenous, why this point is important for you for psychiatry?
Factitious.
Thank you so
Factitious.
much. That's another point which they can ask you about factitious. First point can come about diabetes. Second point can come about thyroid. You have the
Dr.
patient.
Abdullah,
Yes.
can you please repeat this point from thyroglobulin if it is high and if it is low?
Yes. Thyroglobulin, it is a hormone which is reduced, or it's, what is thyroglobulin? It's the hormone.
Is the pro-hormone.
Thyroglobulin is a protein which will bound with thyroid
Yes,
hormone
it's not a
and
hormone.
make them inactive.
Yeah.
T4 mostly they are bound.
So thyroglobulin, it is produced or made by your thyroid gland. If your thyroid gland is working and functionally working, you're gonna find your thyroid gland releasing thyroid hormones plus thyroglobulin. So in this condition, you're gonna think about if you find it high, These hormones, it's coming from the thyroid gland itself. So it's going to be thyroiditis or iodine exposure. If you are thinking that your
Energy
thyroglobulin,
saving plug লাগাইছি energy saving
guys, please. Please, guys, keep the mic closed if you are not
Okay.
listening.
Okay, so serum thyroglobulin, if it is raised, means there is a hyper, means the other like thyroid hormones are elevated.
It's not hyper.
No, I'm
It's
just giving an
yeah,
example that if thyroid is working, that means thyroglobulin will also
that's
be
gonna be high. Yes.
increase in blood.
Yes,
Okay.
yes. If the thyroid hormones in your blood coming from the patients or is coming from the same thyroid gland in the body, it's gonna be high. If the patient is taking pills to get the thyroid high or the thyroid hormones high, it's gonna be low.
Okay.
So we said that if your thyroglobulin is high, you're gonna think about thyroiditis or iodine exposure. What does the iodine exposure mean for you? It's iodine-induced thyrotoxicosis, yes?
Yeah, iodine induced.
Yeah, so it's iodine induced. So the thyroid itself is still working. That's why you have it high here.
Iodine can cause both hypo and hyper, but here we will just have to think for a
You are
hyper.
thinking about the hormone which is produced. Now you
Okay.
are trying to locate or you are trying to differentiate. Is it hormones which is coming from the body itself? Or it's the lady, she is getting hormones from outside? This point, it can be applied on hypo and hyper, the exogenous. So if the patient is taking PTU, what's going to happen? What's going to happen to your thyroid hormone? Is it going to be increased or decreased?
Will decrease.
It's going to be decreased. So what's going to happen to the thyroid or the thyroglobulin?
It will decrease.
It's going to be decreased. So the thyroglobulin, it's came to you here under low to differentiate. Is it low and is it thyroiditis or iodine? Or is it low and it's happening because exogenous cause? If you have a low uptake plus high thyroglobulin, you think about thyroiditis. I need you to remember for me thyroiditis. That's what they love to ask about. If you have a lady with a low uptake and there is a low thyroglobulin, you're going to think about
Exogenous hormone.
exogenous hormone. Next point. We spoke about high. If it's high, what you going to think about? So if it's high, you're going to look for one of two. One, two. You're going to look for the pattern. Is it nodular pattern or it's diffuse pattern? If you find your uptake high, even if there is no ophthalmoplegia or ophthalmopathy and goiter, but you did your radioiodine uptake and you find it high, and you found your pattern is diffuse, they tell you it's a diffuse pattern. What you gonna think about?
Graves.
That's gonna tell you it's a Graves. That's gonna tell you it's Graves. So you're gonna make an arrow like this. Graves. If it's nodular, they love to ask about this. What you gonna suspect?
Toxic nodular goiter.
Toxic.
Nodular goiter.
Okay, I need you to remember for me. Toxic adenoma or multinodular goiter. Again, I'm gonna repeat the two charts which we did make now. Someone gonna repeat everything after me. Please concentrate. I'm gonna ask you to repeat it now. First thing, when you have a patient or when you are trying to differentiate, you are getting a question about primary and secondary, you try to differentiate between them. How you gonna try to differentiate between them? You're gonna check about TSH and T3, T4. If you find them on the same direction, it's telling you it is secondary. If you look for the clinical feature for the secondary or the central cause, you're gonna find a headache and visual disturbances. Plus, if it's a female, what you're gonna find?
Amenorrhea.
Or
Hyperprolactinemia.
hyperprolactinemia. If you're looking for anti or autoimmune antibodies in the central, will you find or no?
No.
No, we won't find. If you are looking for the radio uptake, what you're gonna find?
High.
It's gonna be high or increased. The best next step for your secondary, what you're gonna do?
MRI.
It's gonna be MRI. MRI where you need to remember.
Of the brain.
Yes, please
for the
go and
gland.
look. Yes, look nicely in your options because you're gonna find 2, maybe or 3 MRIs.
No. Just
Yes.
looking for the pituitary adenoma.
Yes. So if you're thinking about you did your TSH and T3 and T4, you found them in opposite directions. TSH is going down, T3, T4 is high. What you gonna think about?
Primary.
It's primary. If you are thinking about it's a primary, you are thinking what is the best next step for you now? What you gonna do?
So look for signs, eye signs.
Look for the Graves' disease signs, goiter or ophthalmopathy. If you go and look for goiter and ophthalmopathy and you find them, it's Graves. If you go and look for your goiter and ophthalmopathy and you don't find them, what you gonna do next?
Video.
You're gonna do your radioiodine scan. Yes, you are trying to find out what is the 2 results you're gonna have from radioiodine uptake. Either it's low or high. Let's go if it's low. If it's low radioiodine uptake, what is your suspicion here? Thyroiditis. But how you gonna find out is this patient is having really thyroiditis or they took something from outside?
You need to check the
Thyroglobulin. If you find your thyroglobulin is high, what you gonna think about?
Thyroiditis or iodine
Exposure, yes. And if you think about a low,
then exogenous exposure.
yes. If you are thinking about radio uptake is high, what is gonna come to your mind? What is the question you're gonna ask yourself?
The uptake pattern.
The pattern.
Or nodular.
The pattern. Yes. If it's nodular, what you gonna think about?
Toxic adenoma,
Toxic adenoma or multinodular goiter. If they are asking you about the diffuse pattern.
Graves.
Thank you so much. Now, Dr. Stephanie, please pick someone randomly from the group.
Okay. Any voluntaries?
Can I try?
Yes, please.
Okay. Primary and secondary. If it's secondary, we have TSH and T3, T4 are going the same direction. We also have headache, visual disturbances, amenorrhea in women. Sorry guys, I'm at work. Okay. Radio uptake will also be high, and we check MRI in the brain, right? In primary, TSH, T3, TSH is low, T3, T4 is high. So we check the eye signs too. If there's goiter and ophthalmopathy, it's Graves. If we don't have that, then we do radio iodine scan. If it's low, then it's thyroiditis. We check for thyroglobulin. If it's high, we do iodine exposure. If it's low, it's exogenous. If it's high, if there's high radioiodine scan, we do then it's nodular. And for
You check
nodular,
about the pattern.
we check about
Yeah.
the pattern. Yes.
Yes, write it down for yourself. I check about the pattern because that's what you're gonna keep in your head. Once you see a patient is coming to you with a thyroid problem, you're gonna measure for him TSH and T3, T4. You find them in opposite directions, you're gonna think about it's a primary cause. The easiest for you to look in the question is to look for the eye symptoms and the goiter. Did you find the goiter and eye symptoms or no? If you found them, it's Graves, easy for you, it's done. If you don't find them, it's gonna give you a little time. You're gonna go ahead and check about the radio uptake. If the radio uptake is high, what you gonna look for?
Butter.
Pattern. Is it nodular? If it's nodular, what is gonna be your answer?
Toxic adenoma.
Yeah, toxic adenoma. So, or
if it is diffused.
It's diffuse Graves.
okay,
Dr. Abdul, the pattern is it done with ultrasound?
it's done with the radioactive iodine uptake. It's called radioactive iodine uptake patterns.
Okay.
That's why you scan it.
Okay.
I don't think that you can see it with the X-ray.
No, the radioactive agent lights up the area which is producing the hormone, so it produces a pattern.
Yeah.
And the images are taken.
So, okay, that's right. Okay. So if TSH is low, what this is telling you guys, thyroid is high.
Primary.
Then you think, so then you think about,
Primary.
okay, let me give you this point. Let me give you this point because you're gonna find a question in it and then someone's gonna come back, Doctor, we didn't study this. Let's study it here. Dr. Kainet, repeat the chart from the primary or for the primary, get me to this point here.
Which point? This end point?
Yes.
Okay. So for primary hyperthyroid, like for primary in general or just hyperthyroidism?
For primary, I need you to go start from primary and get me to the end.
Okay, so if we are considering primary pathology, whether hyper or hypo, we're going to look for the direction of the hormones. If they're in opposite directions, then we consider it's a primary pathology. If they're both increased, then we consider secondary pathology. If we have increased T3, T4 and decreased TSH, it means it's primary hyperthyroidism. Then once it's done, we look for the features of either Graves' disease or ophthalmopathy. If ophthalmopathy is positive or the signs and symptoms are there, it's Graves, straightforward. But if we don't see ophthalmopathy, then we go for radio iodide uptake. Now, when we have done the scan, we see whether there was an increased uptake or decreased uptake. If the uptake was decreased, then we have a suspicion of thyroiditis, but we need to confirm it. So we check for the thyroglobulin, if to see whether it was endogenous production of the hormone or not. If it's high, then it's endogenous, confirming either it's thyroiditis or the person or they have excess iodine exposure. If the thyroglobulin was low, then it confirms that the source was exogenous. The body was not using it probably. Then coming to the other side, if the radioiodide uptake is high, then we look for the pattern. If it's a diffuse pattern or homogeneous uptake, then it's definitely Graves. But if the pattern is nodular or
That's what I needed from you. It's nodular. If it's nodular, what you need to add here, because you're going to find it in some of the questions. Did you find the pattern nodular focal or it's a nodular patchy? Let me clear this so it's going to be.
So adenoma will be focal because it's just one.
Adenoma, it's going to be, so you're going to have toxic adenoma focal.
Okay.
If you find it patchy, what is the word? It's going to be the multi. Yes. So it's going to be the MNG. So once you reach to nodular, you can have 2 points or 2 words going to differentiate it for you. Either it's going to be a toxic or it's going to be multinodular. Please concentrate. I'm going to ask people to repeat everything we did today. Did you get this point, Dr. Henry and everyone?
Yes.
Did you add it? Yes. So you're going to find it in your capsule as well too. So if you find, okay. Next. Next, there is nothing you could do here except if you write it down. I did attach it for you in your capsule as well too. We're gonna play games here. We're gonna speak about something very important for your exam. Tons of the questions you're gonna find it about it. Canada, Q Bank, ACE, and even your word. We're gonna speak about, please concentrate and write it down. I'm gonna ask people randomly to repeat. You're gonna differentiate between proximal and distal weakness. Proximal and distal weakness. We're gonna think about, first of all, please write it down so you can remember it. If you have, that's number one, your beloved drug, what is the drug which is coming from spend 15 years criteria?
Statin.
Statin. A patient started a new statin. Plus, he's coming to you with myalgias.
Oh, yeah.
What is the best next step for you?
You stop the statins.
Stop statin and check for
CKD or
CK and you're gonna check about CK and
Lipid profile.
renal
renal.
Renal function, yeah.
You are worrying about the kidney. Yes. So you are checking about CK because you are worrying that it could happen or you could have here rhabdomyolysis.
Yeah.
That's why you are checking about it. It's not because statin you're going to find CK is high. No, you are doing this to check about or to follow up or to make sure that everything is okay with this patient. So we are speaking about proximal muscles. Pain. We're speaking about pain plus tenderness plus you could find weakness. If it's happening because the statin, do you think is it going to be symmetrical or asymmetrical?
Asymmetrical.
Symmetrical.
Why it's asymmetrical? It's going to be symmetrical, yes. It's a medication, yes.
It's symmetrical.
So it's going to be symmetrical most of the time. So if you have a patient who came to you with a new statin and they have myalgias, you think about, I'm going to stop this drug now. I'm going to check about CK and renal functions.
Renal functions.
And okay.
Doctor, can you repeat second line, please? The proximal muscle pain.
Proximal muscle pain, tenderness, weakness, which is happening symmetrically.
Okay, thank you.
We are speaking in this condition about statin associated myopathies. SAM. Statin associated myopathy. Next point here, they love to ask you about. What could be the cause that this drug or the statin caused for you this? I need you to watch for interacting medication. Which medications could make an interaction with a statin? Come on, guys.
Azithromycin.
So you're going to think about microlids. Please write it down. You're going to think about microlids or any azoles, antifungals. Or if it's old age, or if it's hepatic or renal problem or disease, or if we're speaking about thyroid, which problem can precipitate it or predispose? Hypo or hyper?
Hypo.
Hypo.
Hypo. So once you find statin in a question which looks like thyroid or weakness, sorry, proximal weakness, you think about SAM. When you think about SAM, you're going to think about, is it a drug interaction? Is it because of the age? Is it because of a liver disease? Or so it's either because of hepatic disease or renal disease? Or is it a hypothyroidism? You're going to think about SAM. What I'm going to check about, first of all, I need to stop the drug. After I stop the drug, I'm going to check for CK and renal function. What I'm going to find? Proximal muscle pain plus tenderness plus you're going to find weakness. Please symmetrically. Please concentrate. Someone going to repeat all what I'm speaking about now. Number two. Number two is very important. Number two, we spoke about SAM. Here, we're going to speak about polymyocytes. Polymyocytes. How are we going to find polymyocytes? We spoke about it before, but we're going to repeat it here again. They love to give you, what is going to be more in polymyocytes, weakness or pain?
Weakness.
So they're going to write for you, weakness is more than the pain. Plus, what you're going to find here high?
Really high CK.
CK.
CK. CK in SAM, it's usually going to be normal, except if you have rhabdomyolysis. So it's a weakness. It is more than the pain. You need to think about inflammatory myopathies. If you think about inflammatory myopathies, what's the other word of it?
Polymyositis.
Polymyositis. How the patient here is going to be present to you? They're going to write to you the patient. Yes.
PM, is it the same thing as PMR?
No.
No.
This is polymyositis in general.
This one is polymyositis. What is the PMR, Dr. Henry?
Polymyalgia rheumatica.
So is it the same thing?
No.
No.
No, it's not the same thing. We did differentiate between them. We're going to go just quickly through them. I can repeat it again. So I need you just to remember this for now. You have symmetrical proximal weakness. They're going to describe it to you in your questions as the patient is having difficulty climbing stairs or
standing from the chair,
raising from the chair,
Yeah.
or lifting arm. You're going to find this patient with a pain which is less prominent than myalgia, maybe. You're going to find CK is
high.
Yes.
So CK is high. You're going to find the weakness more than the pain. You're going to think about inflammation is going on here. How to differentiate between this and the one SAM? SAM, you're going to find in the history, statin. Yes? SAM, you're going to find statin. SAM, is it, which one is more? Myalgias or pain?
Myalgias.
What do you think? Myalgias is more. There is proximal muscle pain, but there is weakness as well too. It could be equal, or it could be maybe the opposite than PM. PM, what we're going to find more, it's weakness more. SAM, you can find both of them, myalgias or pain. Sometimes they are equal, sometimes it's hard to say which one is going to be more in SAM. So you're going to look for the history. Is this patient took a recently new medication? Did he take statin or another drug which interacted with the statin? You're going to think about microlates. You're going to think about the azoles. Yes. Is this patient is elderly? Is he present to you with a liver or a renal problem? Is this patient is coming to you with hypothyroidism? So if you have weakness more than the pain plus CK is high.
Polymyositis.
SAM, CK, it's going to be normal unless you have rhabdomyolysis. So next, number 3. Number 3, we are speaking about thyrotoxic polycythemia. neuropathy. This one is easy.
Dr. Abdullah, in polymyositis and in statin-induced SAM, there will be the symmetrical proximal weakness or distal weakness as well.
It's going to be proximal in both of them.
Okay.
Proximal muscle, but there is something different here. There is a proximal muscle weakness and proximal muscle pain.
Yeah, penin will be in statin SAM.
Yeah, pain is mostly it's going to be on the statin. So history is very important to differentiate between the two proximal muscles, because not all the time they're going to tell you, oh, it's pain, is it this, is this, yes, but they're going to give you history as well too. That's why, or that's how you're going to differentiate between them. Otherwise, sometimes it's a little hard because CK can be high in both. But you are thinking about weakness more prominent for you in your
Polymyositis.
polymyositis. And you're speaking about the statins, they love to mention for you myalgias. So it could differentiate it for you as well too. So history and the presentation is important. Number 3. Thyrotoxic polyneuropathy. Please write it down. Thyrotoxic polyneuropathy, why it's happening or where we're going to find it with your favorite, thyrotoxicosis. What you're going to find or what is your findings here? They love it. You're going to think about distal weakness. Plus, please write it down. Someone going to repeat all what I'm speaking about. Distal weakness plus you're going to find sensory symptoms. What is the sensory symptoms? We're going to find it with that thyrotoxic polyneuropathy, which is happening with toxicosis. What is the sensory symptoms? Remember that we said here, it's distal, it's not proximal. So if it's distal, sensory, so you're going to think about numbness or tingling. In this patient, you're going to find decreased reflexes. So please, guys, keep the mic close, please. Dr. Denidra. Dr. Denidra.
Yeah.
Please, guys, keep the mic close. We have short time. Please. We have short time. I need to finish for you much. Okay. I need you to remember the next. Please write it down. If they ask you about distal plus, they're going to tell you that there is a sensory problem. That's why I did mention for you 2 points. What it is?
Tingling and numbness.
Very nice. So they're going to give you a distal plus tingling and numbness plus. They're going to give you hyporeflexia because we said that the reflexes, it's going to be decreased. So they're going to give you hyporeflexia. So you're going to think about what?
Thyrotoxic polyneuropathy.
Yes. You're going to think about neuropathy. And definitely look for thyrotoxicosis. Do you see the difference between the neuropathy and the myopathy?
Yes.
Myopathy, that's the inflamed myopathy, which we spoke about it with the polymyocytes. Polymyocytes, it's weakness more than the pain. CK high, and you're going to find it on the proximal muscle symmetrically. Neuropathies, it's telling you sensory problem from the name neuro. Reflexes, it's going to be decreased. Thyrotoxicosis. And it's happening in proximal or distal?
Distal.
Distal. Very nice. So, never say that it's myo, because that's what they love to confuse you. If you find sensory, once you find sensory and decreased reflexes, please do not call it polymyocytes or myopathies. It's neuro.
Dr. Abdullah, what is the
Yes.
T that you have written?
It's tingling.
Okay. Thank you.
Thank you so much. So,
what's the O above? Where you have macrolides, azoles, there's an O before hepatic renal.
old.
Huh?
Old.
Old age. Oh,
Yes, old age.
okay.
Yeah. Number 4. Number 4, we are speaking about the upper motor neuron. Mainly, we are speaking about primary lateral sclerosing pattern. If you're speaking about the lateral sclerosis, guys, primary, we're speaking about upper motor neuron lesion. Where or what is the problem or what's gonna happen here? Here, it's very easy to find it. You're gonna find spasticity. You're gonna find stiffness. You're gonna find it clumsiness. You're gonna find slowed movements. You're gonna find hyper or hyporeflexia?
Hyperreflexia.
Hyperreflexia. So is it easy for you to differentiate between the lateral sclerosis pattern and your neuropathy?
Yes.
Neuropathy, what's gonna happen?
Hyporeflexia.
Hyporeflexia and sensory. Here you have S's, so many S's here. S, spasticity. S, stiffness. C, clumsiness. S, slow movement. H, hyperreflexia. Can we find Babinski here or no?
Yes.
We may find Babinski. We may find Babinski. So they're gonna come down to you. Definitely, they are not gonna give you everything to make it easy, but they're gonna give you hyperreflexia. Plus, one of the guys on the top, one of the S's which you saw, maybe they're gonna give you spasticity. Will you think about myopathy here?
No.
No.
Myopathy, what's happening on it?
Hyporeflexia.
This pain in the muscles and
Myopathy, we're speaking about
Oh, myopathy.
myopathy.
Weakness.
Weakness.
We're
movement.
speaking about
Pain.
weakness.
Yeah.
If you're speaking about neuropathy, doctor, that's the one which you're gonna find decreased
Sensitivity.
reflexes.
Yes.
Did you get it?
Sensitivity.
Yes.
Here you're gonna find increased reflexes. Did you get it? So here you're gonna find the increase or hyperreflexia plus spasticity. So you're gonna think about upper motor neuron lesion. It's not thyroid myopathy. Did you get it? If they tell you proximal and distal, what is the two proximal we did study?
Statin and polymyositis.
The SAM and
Polymyositis.
the SAM and
polymyositis.
which one? It was the distal.
Is thyroid neuropathy?
Thyroid.
Yes, the primary or the upper neuron syndrome, it's looking different. It's spasticity, it is stiffness, it's clumsiness, it's slowed movement, it's hyperreflexia.
Positive Babinski.
Babinski could find it positive as well too. So never call this a myopathy. Now you remember the myopathy, please write it down. I did add for you all the information in your capsule, but you are required to write it down because you're going to send your notes after the session. Please study because we're going to have another session. I'm going to ask people to repeat everything from today. Next point, I need you to remember. That's number 5, guys. Number 5, I need you to remember the chronic hyperthyroid myopathy. So what is the condition we got it with the thyrotoxicosis?
It's
Distal
polyneuropathy.
What it was?
Thyrotoxic polyneuropathy.
It's thyrotox. Say it again.
Thyrotoxic polyneuropathy.
So we did study the thyrotoxic polyneuropathy. It's happening with thyrotoxicosis. It's happening where? Where is the weakness?
Distal weakness.
So it's thyrotoxic polyneuropathy, neuro. Now we are studying the chronic hyperthyroid myo. Once you see word myo, is it proximal or it's a distal?
Proximal.
Proximal.
How about neuro, Dr. Henry?
Distal.
Distal.
So it's going to be symmetrical proximal muscle weakness. Here you're going to remember it is painless. Did you get it? We're going to repeat them all. So now you have 3 for the proximal. Please give me your 3 things for the proximal. The easiest for you, once you find it painless, think about a chronic hyperthyroid myopathy. If it's painful, what are you going to think about?
Polymyositis.
Sam. Think about Sam. Sam. Because polymyositis, what is more prominent?
Weakness more than pain.
So you're going to write for me the next in your lovely notes. Proximal muscle. If you find weakness more than the pain, you're going to say it is? Polymyositis. Or what is the other name?
Myopathy.
Inflammatory myopathy. If it's not this, if you have a proximal muscles is affected and they are telling you it's painful happening here or painful plus weakness, they didn't tell you which one is more. It's going to be, and history, definitely history. It's Sam. If they give you the proximal muscle and they tell you it's painless, it is?
Chronic
hyperthyroid myopathy. If you notice, all myopathies is affecting the proximal. One is painless, one is painful plus the weakness, one is the weakness more than the pain. Did you write it down? So if they give you a hyperthyroid features.
Dr. Abdullah,
yes.
Can you please repeat in between polymyositis and chronic hyperthyroid myopathy that both are painless?
No. Polymyositis more its weakness more than the pain, but there is pain.
Okay.
Yes, The other one, it's painless. And which one you're going to find are thyroid features or hyperthyroid features? So it's not only painless, but you're going to find hyperthyroid features. Will you find the hyperthyroid features in polymyositis?
No.
No. What is the hyperthyroid features, doctor, which you need to write in your notes? It's weight loss, maybe. Yes. Maybe it's a heat intolerance. Maybe it's a tremor. Maybe it's a tachycardia. Did you find it? Did you get it, doctor?
Yes.
So if they give you a proximal muscle weakness plus weight loss, tachycardia, brisk reflexes, what you gonna think about?
CHM.
Chronic
CHM. It's
hyperthyroid.
yes, it's a chronic hyperthyroid myopathy. So yeah, that's the 5 points which I wanted to give to you about
Dr. Abdullah, in proximal muscle weakness, there will be the three things: polymyositis, chronic hyperthyroid myopathy, and SAM.
yes.
Now, depend upon the painless and painful, we have to
And the
differentiate.
history. Yes, painful, painless history. You did get all the points for it.
Okay,
Plug
and
in
you
the
said
And Sam, is there weakness apart from pain?
you're gonna find pain and weakness both.
Okay, it's all right.
yeah, because this point is quite confusing, so that's why I'm just confirming.
No, that's okay. Now you did digest it. Now you have no reason to confuse them.
Yeah.
Now you did find them. It's upper motor neural lesion, or if you are thinking about, if it's upper motor neural lesion, what else? What we spoke about?
Yeah, it's the primary lateral sclerosis.
Lateral sclerosis pattern. Yeah, so it's gonna find the S's which we spoke about: spasticity, stiffness, and slowed movement. You're gonna find hyperreflexia. You're gonna find yes, increase the tone. Babinski could be there too. Yes, so hyperreflexia, spasticity. You're gonna think about upper motor neuron lesion.
Yeah, and remaining all
If
these
it's
are
thyrotoxicosis is the cause and you find the distal, not the proximal, what is your answer?
Thyrotoxic polyneuropathy.
It's neuropathy. It's not myopathy.
Yes.
So what we spoke here, it's not about only proximal muscle, but you can write on the top here, it's myopathies. If it's neuropathy, it's gonna affect for you the distal. Did you get it?
Yes.
Did you get it, guys?
Yes.
So, okay. Next point. Next point is very important. I need you to remember it and write it down because I'm going to ask people to repeat everything. Someone going to repeat every single word we are speaking about right now. Next point which you need to remember here. I need you to write TBG.
Dr. Abdullah, before you move on, Doc, how do we differentiate between proximal muscle weakness and the distal muscle weakness? I know that proximal muscle weakness is the
You're speaking about
myopathies.
myopathies and you speak about the three things. If it's neuropathy, you're going to think about the distal. So if you find a thyroid problem and you find distal muscles, not the proximal, you're going to think about the neuropathy. It's not
Right. Right, but I was thinking like, for example, we said that proximal muscle weakness, it's difficulty standing up from the chair, raising your hand, climbing the stairs. How would you describe then distal muscle weakness? You gave the associations, but the presentation itself.
I think that this we have a little bit more of like, as the doctor mentioned, the sensory symptoms, like that tingling and numbing. Like that's how they kind of, because that's kind of what is gonna be present too in like diabetic neuropathy and all the neuropathies that have like tingling and numbing and all those symptoms.
Distal, if it's distal weakness, it's gonna be just it's further from the trunk, Dr. Karan. So if it's distal, think about it. You are thinking about maybe the hands, the fingers, the feet, the toes, and
Like glove and
ankles.
socks pattern.
Yes, yeah. So how about the
People
proximal?
have
Where
difficulty buttoning their shirt or something like that.
so you're
Maybe
gonna
that's
think,
how they would describe it.
yeah. So they describe it for you. Maybe they cannot bottom the shirt,
They
or they
cannot grip the
cannot
object.
jar or lift the toes. You're gonna think about distal. If they tell you that the patient cannot comb the hair,
That's
the patient,
proximal.
that's a proximal. Patient cannot raise from the chair,
Proximal.
it's a proximal. If they tell you the patient cannot bottom just the bottom the chair, he's not able to close his shirts. Sorry, he cannot button the shirt which he's wearing. You're gonna think about distal. He cannot use his fingers.
Yeah.
It's
I just
usually
looked it up,
neuropathies.
doctor, and it said like gripping, difficulty gripping objects, dropping things, difficulty buttoning clothes, trouble
Yeah.
opening jars.
Writing,
Right.
Yes, because you
buttoning
think,
shirts, gripping objects, that's all distal and it all comes under neuropathies. And
yes,
proximal muscle weakness, difficulty climbing, standing on from a chair, lifting arms, that's are all myopathies.
yes, they can give you upper limb, lower limb, and the proximal. They can give you the patient cannot comb his hair. He cannot, or he's having difficulty to brush his teeth. He's having a problem reaching over the head, difficulty lifting objects into, or sorry, onto the shelves. Patients having a problem with the raising from the chair. Patients having a problem with the climbing the stairs. The patients having a problem or difficulties getting up from the floor. Any of these we're
For distal, let's remember the stocking and glove pattern because that's kind of where the symptoms are gonna
yeah,
distally.
so when you think about proximal muscles, you're going to think about all the myopathies. We spoke about three of them, yes, polymyositis, SAM, and the chronic
Hyperthyroid myopathy.
myopathy. Yes, or the hyperthyroid myopathy. So any myopathy, they can add on it for you Cushing, they can add dermatomyositis too, because it's still myopathy too. Did you get it, Dr. Karan?
Yes, Doc, I got it. Thank you so much, Doc.
Thank you so much. My appreciation to your gray matter.
So, doctor,
Are you using 3 devices, doctor?
So, but PMR also have similar features with some of this proximal myopathy.
PMR, I didn't want to go through it now because it's gonna give us a little confusion since we're speaking about these guys. But if you need to speak
Okay,
about
sorry.
PMR, no, let's do it. So PMR, what we're gonna find in PMR?
Same thing.
It's
The
stiffness and
pain,
pain, more than
pain
weakness.
and weakness, but pain more than weakness.
I think pain will be more than
CK2 will be
weakness.
high. ESR will be high.
So
CK will be
here
normal.
in polymyalgia rheumatica, you're gonna find pain is more dominant.
More dominant.
Yes.
Polymyositis, you have the weakness more dominant, or you have the weakness is showing more than the pain. That's the first thing you differentiate between them, Dr. Henry.
Yes.
Age here is very important.
Yeah, more than 50.
More than 50. Morning stiffness definitely here, more than 45. and they have a problem with the trouble getting of bed and so on. Any question on the proximal muscle, you need to know it very nicely. Why? Because they love it. They love to tell you that you have a patient who's coming to you, he's not able to do any above the head activities. So you need to think about it. I did include it for you in the capsule anyways. So now people, they're gonna get me crazy to get the capsule very soon.
Yes, please. Dr. Henry, also I think the pattern, that's kind of how I pick in the questions. They always mention shoulders and hip.
And the CK too, Dr. Stephanie.
Yes, but like the distribution of the pain is going to be more shoulder, neck, and hips. And yeah, the CK, of course, is going to be elevated in polymyositis, but in polymyalgia rheumatica, they always mention problem in their hips, shoulders, and neck. That's kind of where the pain is going to be located.
Yeah.
Mhm.
Okay. Let's
Is
move
it a
this.
proximal myopathy?
Yeah, it's a proximal myopathy.
Okay.
PMR.
Yeah, it is proximal.
Yes.
So CK will be normal in PMR, right?
Yes.
Only ESR will be raised.
But you are saying proximal. Are you speaking about weakness here? There is no weakness in PMR.
Yeah, there is no
Why
weakness.
you are saying it's a proximal? So proximal, what do you mean with the proximal?
Which the pain is going
They
to be
also describe them as difficulty standing from a chair, climbing stairs, and things like that.
Yeah, but it's pain, yes.
Yeah.
You're gonna find, I would say more instead of proximal. I need you to remember it's a bilateral shoulder or hip pain.
Pain, yes, pain.
Yeah, it's more specific. PMR, you're gonna find stiffness, but you get or pain sometimes. Weakness is more. Sorry, no, that's polymyositis. Yes, in PMR, you're gonna find pain and stiffness. You're gonna find normal strength and normal CK.
Yes.
In polymyositis, you're gonna find the true proximal weakness. And you're gonna find CK is
elevated. Those are the key.
Yes. PMR, what you're gonna find elevated?
Yeah.
Inflammatory markers, the
ESR.
ESR and CRP. Yes, so you're gonna check about them. Okay, let's move on, guys, because I have few things I need to finish for you now. TBG. We're speaking about TBG. What is TBG?
Thyroid binding globulin.
So, okay. So we're gonna speak about the changes here. We're going to speak about 2 points as usual. Please write it down. Someone going to repeat everything today. Let me get the charger. Okay. So, TBG. As usual, high, low. If TBG is high, I need you to remember the next. What's gonna happen to your T3 and T4?
TIBG will be high, then they will be low.
If it's high, these guys, they gonna
decrease.
Unfortunately.
Yeah.
High.
Increase.
Why low?
Is endogenous reduction.
Yeah. Why you are saying it's gonna decrease the opposite? It's gonna be the same thing.
Yes.
So
That's a binding capacity.
yeah.
Okay.
So TBG, just to understand, write it down so you can remember it. TBG is very important. If you find TBG is high, what you're gonna find? It's thyroxine binding globulin. The job of this, please write it down. So make a small arrow here and write it. I'm gonna check about all of you. The job here is to bind and transport thyroid hormones in the blood, mainly T3 and T4. It's the main transport protein for the thyroid hormone. And to know and understand why it's important, it carries about 75% of the bound thyroid hormone in the circulation. So it's very important. So if you find the binding, the hormone, or sorry, the protein which is helping the hormones or the T3, T4 to bind high, what's going to happen to T3, T4 levels?
High.
It's going to be high. So it's going to be high. Now we're going to take the next. So TBG, it's going to be binding and transporting the thyroid hormones in the blood. If you find the binding protein and transporting protein high, you're going to find your hormones high. If you find them high or TBG high, what is the causes TBG could be high?
In case of pregnancy.
Yes. So it's not, I don't need you to remember pregnancy. I need you to remember another word more important than pregnancy. What it is?
Estrogen?
Estrogen state. Because if you think about estrogen state, you're going to think about pregnancy. You're going to think about OCPs. You're going to think about HRT. Next, we're going to speak about what can increase it again, guys. What else?
Hyperthyroidism.
Acute hepatitis, sorry.
Okay.
Acute hepatitis. TBG, if we're speaking about TBG, we are saying it's the protein which is transporting and making your thyroid hormones binding. Where it's made?
Liver.
The liver.
It's made in the liver. That's why we said if there is acute hepatitis, you're going to find maybe higher TBGs. Did you get it from where it came?
Yes.
Estrogen. Why estrogen? We spoke about it here. What is the estrogen effect on your liver?
Liver metabolizes estrogen. So
estrogen, if it's increased, it's going to affect your liver to increase the production of TBG. That's why we say any condition where you have a high or excess estrogen, you're going to find TBG high because the estrogen affecting the liver, affecting the TBG, it's going to be high. And if you have high TBG, you're going to have high T3, T4. What is the conditions which is causing high estrogen, pregnancy, OCPs, HRT? Did you get it, guys, from where it came?
Yes.
Next point. If you have a low TBG, what's going to happen to T3, T4?
Low too.
Low. Same direction. Remember, T3, T4, and TBG, same direction. Just write it down under the definition which you wrote. TBG and T3, T4, always the same direction. If it's low, what you're going to think about? What is the causes which can decrease for you the TBG? Number one.
Cirrhosis.
Chronic liver disease. So acute hepatitis can increase it. Chronic liver disease can decrease it. Next, 2. What can decrease it?
Nephrotic syndrome.
Nephrotic syndrome, but I won't go and speak about nephrotic syndrome here first. I'm going to say something more.
Factitious injection of thyroxine supplement can also decrease it. Like in factitious disorder.
I need you to remember protein loss or low protein. Here you speak about nephrotic or nephrotic syndrome, severe malnutrition or starvation. Did you get it, guys?
Yes.
All of them questions. 3. Glucocorticoid is the next. Number 4. Number 4.
Androgens?
Androgens or?
In case of Thyroid 6 syndrome, because there is the maybe it's due to the infection or any kind condition. Patient is sick, so maybe it will decrease TBG. So it will lead to hypothyroidism. So maybe TBG will decrease in that case.
What is the difference, doctor, between anabolic steroids and glucocorticoids? Is it the same thing?
No.
So what is the difference between them? Anabolic steroids and glucocorticoids, both of them steroid hormones, but they are very different. We say that glucocorticoid is number 3, number 4. It is androgen and anabolic steroids. AA, androgen anabolic. Anabolic steroids mainly androgenic or testosterone-like. Glucocorticoids, it is cortisol-like. So if you are thinking about, please write it down, it's important. If you are thinking about your glucocorticoid, you are think about stress or anti-inflammatory. So the main effect, it's anti-inflammatory, immune suppressive, increase the blood glucose, yes? So affect maybe the fat redistribution, and long-term use it's gonna cause for you, please write it down, I'm gonna ask about it. Muscle breakdown. And you're gonna know why I'm telling you about this now. Examples of the glucocorticoids, it is cortisol, pre, why no one is saying anything? Cortisol or? Prednisone, dexamethasone, or hydrocortisone.
All the steroids.
Yes. So we said it's a muscle breakdown. If we're speaking about the anabolic, you think about, so glucocorticoid, we spoke about stress or anti-inflammatory. Anabolic, we are speaking about something very interesting here. We're speaking about build. So you are thinking about increase the muscle mass,
Yes.
increase the protein synthesis, and promote the male secondary sex traits.
Yeah.
Examples of the anabolic, it is testosterone or any other androgen example. So one is anti-inflammatory and stress. The other one is building, increasing the muscle mass, it's increasing the protein synthesis, and so on. One with the long use, it's gonna do destruction. One is building. Did you get the difference between them?
Yes.
Dr. MBD is metabolic destruction.
It's muscle breakdown.
Muscle breakdown.
So, and unfortunately, this information is added to you in
Capsule.
capsule. So, unfortunately. Yeah, I think we can do maybe 10 more minutes or 15 minutes. I need to finish for you a few things quickly. So, you're gonna love this capsule this time. So,
When it is coming.
after we are done with the chapter, everyone, you need to do your tasks. You need to do more questions. I'm gonna provide you with your capsule. Let's see what we can do now. I'm gonna finish for you the EU thyroid sick syndrome. EU thyroid sick syndrome. You have more than enough time, guys, to study endo, because I'm gonna do my best to finish the rest of the things today. You're gonna be left to do yeah, we're gonna be left to do infectious diseases. So okay, next point.
The recording of the class last night, or that will take a while.
Last night,
Mm-hmm.
what did we do last night?
Diabetes and I don't know. I
I
couldn't
said
attend.
yeah, we did diabetes. We did just go through the book.
Okay.
I don't think that you missed much yesterday. We did speak about DKA and so on. We did go just through the book quickly. The most important, the heavy part, which you are attending now, Dr. Stephanie. I was
Who
thinking maybe
knows? I step out 10 minutes and I am like, you're done with half of the chapter. So
so yeah, today we're gonna be done with the chapter. We're gonna do our best to finish it today all.
okay.
So okay. So you're gonna remember for me all what we have done today. First table, primary, secondary. The second, how you're gonna navigate through the investigations and so on. The third one, you're gonna go for the proximal and distal. The fourth thing which you're gonna come here and remember, it is your TBG, yes? And the fifth, that's what we're gonna do right now. The fifth is very important for your exam. It is called, so it's number 5. That's what you need to remember. I'm gonna come afternoon, after we come back to join the session, I'm gonna come back to ask you about it. The one which you need to remember here, it is the EU thyroid sick syndrome. What is the other name of it? Non-thyroidal illness. Euthyroid sick syndrome or non-thyroid illness. Very important, please start right after me because I'm going to check about your notes. Please study. What they're going to write for you. It's seen with a severe acute illness. Where are you going to find these conditions? First of all, any stressful condition, tell me please.
ICU patient.
ICU patient.
So I need you.
Government.
Who's coming to the ICU? Is it only patients who's coming to the ER, or who we can add them to ICU? It could be post-op.
Surgery.
Yes, post-op ICU, or any patient who's in the ICU. Patient, we are speaking about severe acute illness with the sepsis. Patient with maybe MI. Patient maybe with trauma. Also patients who's taking some of the medications. Which the medications you're going to think about here? High glucocorticoid or glucosteroids. The last one, they love it. You word. Dopamine. So you're going to remember the causes. It's very important for your exam. The next point which you need to remember here, very important. The next point, what's going to happen to your T3?
High.
Ha 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 ha.
T3 will be
Think.
It will be low.
Should be low.
Dr. Stephanie.
That's
Normal or low?
Euthyroid sick syndrome.
T3 will be low.
Low.
C3 will be low.
TSH T3 will be normal.
TSH and T4 will be
So
normal.
that's why
Dr.
TBG will
Stephanie.
also be low.
Yeah.
T3 and T4, what's going to happen?
In this one, the T3 is the only one who kind of have changes. TSH and T4 gonna be
Okay.
normal.
No. So
You T3, it's going to be low.
Okay.
Initially low T3. Initially low T3, it can be followed by low TSH. And you're going to make another arrow and you write if it's severe. You're going to find low
T4.
T4. How are you going to find out that this patient is recovering from the euthyroid sick syndrome?
When the TSH starts increasing?
T3 starts to, normal.
So you're going to find out, please write it down. Dr. Stephen, I'm going to ask you specifically to repeat it. You're going to find it recovery if you find your TSH transiently increased and they give it to confuse you on the questions. T3, it's going to be low. It's going to be followed by
Low TSH.
TSH.
Followed by severe low T4.
If it's severe.
But doctor, why is TSH low when T3 is low? It should be high.
You are speaking here about a stressful condition.
But
yes.
The question, so like it's T3 is low, TSH is normal, and T4 is normal too. So is that when it's not that severe? Or mild cases, or?
Say again, Dr. Sifri, please.
Sorry, that the questions I have done, they usually present the patient with the T3 is low, but then TSH and T4 are normal. So
yes,
is that for a mild or
no. It's the start of the disease, Dr. Stephanie. Then
the beginning.
The beginning.
Okay.
Yes. So you can find TSH here.
Condition.
You can find TSH here normal or low normal. The same with the T4, you can find it normal or low normal. But both of them, you can find them decreased usually when the disease is progressing.
Okay.
Yes. So why TSH is low here if we have both of them is low? Because you are speaking about a severe illness which is suppressing the hypothalamic pituitary thyroid axis.
Yeah.
Did you get it, doctor? Someone was asking about the TSH.
Yeah, that's why it's called euthyroid.
Euthyroid, yes.
Normal.
Yes.
It's not.
Yes. So the main thing is your T3 is going to be low.
Mm-hmm.
Both TSH and T4 can be normal. Can be normal. And that's what how they confuse you. But then when you progress or you have the disease is progressing maybe with the time, you're going to find it decreasing the TSH. Then if it's a very severe condition, you didn't treat it maybe, you're going to go and find your T4 is low as well too.
Thank you. Okay.
My appreciation. First line treatment.
It's just observe.
It's not observe. You
I
need
mean,
to.
supportive treatment, but we don't really treat.
No, first of all, Dr. Stephanie, you ask yourself why this happened to know what you're going to treat with. Treat the underlying disease. If it's sepsis,
Yeah.
you cannot observe. You need to treat it definitely, yes? So treat. Will you give a replacement hormone here?
No, that's what I mean. We are not treating here the thyroid. We are just going to observe the thyroid.
Yes. Never start your the thyroid hormones here. Do not give thyroids. Treat the underlying illness and recheck the thyroid tests after recovery.
Mm.
ICU patient, low T3 and non-classic thyroid story. They're going to play with you a little game. What are you going to think about? What are you going to do here? What is the management? Observe as Dr. Stephanie, she is saying. ICU, Dr. Stephanie. Yes? That's when you observe. Patient is coming to you with a sepsis and low T3 and not regular story for thyroid. You're going to do? Treat the underlying cause and observe.
Yes.
Yes? So observe it was correct. What you need to remember when you're going to observe, when you need to treat definitely what you have first.
Yeah.
So next point. Life is hard with the QE1, guys.
Really hard.
Yes, yes. You need to keep pushing. Yes, the more you study, the more you get exposed to more vignettes, the more you do this and that, you get yourself ready here, the more you're going to be finally ready for your exam. Even if you think that, oh, I don't see improvement, you don't need to see your improvement. You don't need to see it right away. You are improving. Your information, your knowledge, your approach to the questions is improving. You are working hard here. The moment you stop, oh, I'm gonna stop. It's tired. I'm getting bad scores. I'm not passing the mocks. I feel that I'm so stressed. You will never improve. All the layers which we have during our sessions, it was just added with a feedback from someone to solve a problem. So the final 3 months, which you see here, the G7, that's just the final plan. After many before you, did he go through it and they give, oh, I have a problem at this point. Oh, I have a problem at this point. That's why the tasks which you see, the checklists, you see as well to the questions which is required from you. You see as well to so many things which is coming, the mocks, the quizzes and so on. So all these things is made just to help you to study more. Okay, thyrotoxicosis. Let's finish thyrotoxicosis, then we can call it for now. And definitely we need to meet later today. So thyrotoxicosis, what we gonna do with the thyrotoxicosis? What is thyrotoxicosis? Yes, if we finish thyrotoxicosis, almost we are done. Almost. So that's number 5. Did you remember number 5, guys?
Thyroid syndrome.
Thyroid 6.
6 syndrome.
Yes, number 6. Number 6 is gonna be your thyrotoxicosis. Thyrotoxicosis, I need you to add next to it 1, 2, 3, 4, 5, 6, maybe just the full page. SARS, important. Thyrotoxicosis, what you're going to find? I need you to remember the first two things. 1, 2. What is the heart problems which you're going to find here?
Tachycardia.
Tachycardia, yeah. Arrhythmias.
Arrhythmias, yeah.
I need you to remember two things here.
Okay.
I need you to remember sinus tachy and
Yeah.
your favorite, AFib.
Atrial fibrillation.
AFib.
Yes.
So you're going to remember for me the rhythm, and then you're going to remember for me the next. All increase. So I need you to remember all increase or up, except one is going to be down. What is all the ups which you need to remember? Heart rate is up. Contractility, please write it down, up. Cardiac output, up. Systolic blood pressure, up. Systolic blood pressure is up, and the wident pulse pressure, it's going to be up. What else is going to be up? Myocardial oxygen demand. All of them questions, guys. All of them up. They ask you about them. All of them up. That's why I did collect them for you. All of them up, except one is down. What's going to be down?
Diastolic blood pressure.
Systemic vascular resistance. Thyro or the radio uptake here. So you're going to remember this number 1. What is the rhythms you're going to find? Number 2, you're going to remember for me what is going to be up here and what is down. Number 3, I need you to remember for me the next. What's going to happen to the radioiodine uptake? Definitely, you know the answer. It is increasing or decreasing?
Increase.
Increase. It's going to be increase because there is hyperactivity. What are you going to do with this guy? How are you going to treat him?
Antithyroid drugs.
And proper still or
PTU.
Do you start with the
Methimazole.
PTU?
Propranolol.
Methimazole is the first line.
Start with beta blockers to control the symptoms.
Yeah, beta blocker first.
Yeah. Steroids, no?
Isn't thyrotoxicosis like a medical emergency?
Yeah, I think we need to start with the steroids.
What do you need to start with, Dr. Stephanie?
Well, we give beta blockers for sure. But I think, I don't know, I might be mixing it up, but I think we need to give steroids first.
I think
what do you think?
propranolol for the
Okay.
yeah.
Okay. I need you to think about the next. Please write it down. So I need you to think about, just give me 1 second.
Please, can somebody go through the all again? Increase heart rates, increase cardiac output. What's the C? Is it contractility?
Increased heart rate, increased contractility, cardiac output. systolic blood pressure, and myocardial oxygen demand.
Okay. Thank you very much, guys.
So when you have a patient with your thyrotoxicosis, that's number 4, treatment, very important. What you're gonna do, first of all, do not forget that you're gonna go ahead and give supportive care. That's number 1. Number 2, after supportive care, you're gonna go and give, we're speaking about the heart, beta blockers. After beta blockers, what you're gonna do? Number 3.
Thyroid.
Anti-thyroid drugs.
You're gonna go ahead and do the
Thionides, yeah.
Yeah. So you're gonna go ahead and go for the thionamide. So that's number 3, thionamide. Thionamide. The next you're gonna go and do the next after this, what you're gonna do? Number 4. Iodine.
Yes, iodine you have to give.
Number 4. So that's number 4. Number 5.
Steroids.
Number 5, it's gonna be the steroids. Please, guys, close the mic. Please, guys. Steroids. After steroids, you're gonna do treat the trigger. TT. We're gonna speak about all of them now. Let's
Step-up treatment or
it's step-up approach, Dr.
Oh,
Steph.
okay.
That's what you need to keep in your head. You need to have this small letters or map in your head. Because sometimes it's hard. Because when I say for you supportive now, you're gonna remember if it's unstable, ABCs.
Yeah.
If it's unstable, you go ABCs. Guys, please, someone got. Okay, let me see.
Ongoing. No.
Yeah.
So, Dr. Abdullah, for thionides, is there like a...
1 second, doctor. I'm gonna go through it.
Okay.
1 moment, please. I'm gonna go one by one now.
Yeah.
So supportive, you're gonna go for supportive definitely. If it's unstable, you stabilize. IV fluid here. What else? What you could do in the supportive point? What else? Except the fluids and the ABCs.
Cooling blanket and
cooling measures. They love cooling blankets or acetaminophen. So you're gonna write under supportive ABCs, IV fluid, cooling. Could be cooling blankets, acetaminophen, or whatever it is. Yes. And they love in the supportive point to treat the precipitating cause. If you find one, treat precipitating cause. What is the precipitating causes? Infection, surgery, trauma, DKA, MI, stopping the anti-thyroid drugs, anything of these. Did you get it, guys? That's the supportive point. You stabilize the patient, so ABCs, IV fluid, coolings, and then you treat if you can, if there is infection, if there is something, if he stopped the drug, whatever it is. Next, number 2. Number 2, what it was?
Beta blocker.
Beta blockers. Why we need to use the beta blockers here? We are trying to control
the heart rate,
the adrenogenic symptoms. So you give the propranolol. So you give it to treat tachycardia, tremor, or maybe agitation. They love to play with you games. patient is coming to you with a decompensated heart failure or severe asthma. Will you give him beta blockers?
With asthma?
No.
Yes, we
Mhm.
will
About the
give
decompensated heart failure.
cardioselective.
No.
So someone saying the asthma, no. How about the decompensated heart failure? Will you give it with it?
No, even with it.
Both of them you avoid it.
Mm.
Both of them you avoid it. Remember for me this for now. So you need to remember that first, supportive, second, beta blockers. And if you're thinking about beta blockers, you are giving propranolol, and you're going to avoid it in two conditions.
Asthma and
Severe asthma and decompensated heart failure. How about the side effects of this step? They love to ask about it. So they ask you either why you give it, or they ask you about TT. So they ask you about tachycardia, tremor, and agitation, what you're going to give. So you're going to give propranolol. They can ask you when you're going to avoid. They can ask you the next, what is the side effects which could happen because of this medication? Definitely as regular. Bradycardia and hypotension. Why you need to remember about the side effects? Because the next question as well is coming to you. What you gonna monitor for this patient who you give him the propranolol? What do you think?
ECG.
Heart rate.
So heart rate,
Blood pressure.
and the last thing is signs of HF. Did you get it?
Yeah.
No, Doc, could you repeat that point for me, please?
Signs of heart failure.
You have a patient who's coming to you with thyrotoxicosis. First of all, you start with the support. Support, we spoke about few things. ABCs, you spoke about IV fluid, we spoke about cooling. The second point for you is your beta blockers. You are giving the beta blockers here to make sure. Yes, so tachycardia, tremors, maybe agitation, which is happening in this patient. The next point, they ask you about the beta blocker. Which beta blocker are you going to give, Dr. Curran?
Propranolol.
Where or when you're going to avoid to use it, Dr. Curran? Two conditions.
Decompensated heart failure and severe asthma.
Very nice. They ask you what is the side effects, or they can give you the side effects of this medication. So you're going to know. Patients coming to you with thyrotoxicosis, you did treat him, ABCs, and so on. You give him propranolol, and you give him maybe anti-thyroid drugs or whatever it is. They tell you the patient is presenting to you with a bradycardia and hypotension. Which drug did cause for you this?
The propranolol.
Thank you so much. The next point, which they could ask you about it here, a patient who is coming to you and you did check about his blood pressure and about the blood pressure. What you gonna monitor for this guy?
Oh, okay. The heart rate.
You get heart rate, blood pressure, and signs of HF. Sorry, signs of HF. Did you get it, guys?
Yes.
Dr. Abdul, is there need to also monitor the blood glucose, knowing that beta blockers can also show the
Yeah, but
effect?
these guys here is more important for you now. You are worrying about the heart more now. Yes.
I think
So
ACE is more like with glucose.
ACE?
Inhibitors, yeah, they can cause like glucose.
Yeah. So for beta blockers now, I need you just to remember this. Remember this for now. Number 3. Number 3 we spoke about, it was
Decrease
so
vascular
we are speaking about two drugs here, PTU and metamizole. Metamizole. So both of them is important for you. So we're gonna avoid them in which condition? PTU. Let's start with the PTU. Okay. If you find Okay, first line, thyroid storm
Mhm.
or thyrotoxicosis. What is the first line? They're going to give you methimazole and PTU.
Methimazole.
PTU.
Metimazole.
Methimazole is a drug of choice.
Methimazole should be given
In
first.
thyroid storm, the
Thyroid
symptoms are
storm.
overwhelming.
PTU, yes, yes.
Thyroid storm PTU is the answer.
PTU, yes.
Okay.
So you're going to write it down. If it's thyroid storm, PTU is number 1. And if you're speaking about PTU, please write it down because I'm going to ask people to repeat it. You're going to
Dr.
avoid, yes.
Like we are studying thyrotoxicosis, so that means in Graves'
Yes,
disease.
but
So,
just remember this now. Just add
okay.
the information because we're going to go through it. Yes, just add the information. So, yeah, where are you going to avoid it, guys?
Last trimester of pregnancy.
Liver disease.
Liver disease.
Oh, yeah.
Yeah, so, and we're going to speak about pregnancy. So if they are writing for you PTU, they love to ask about the side effects. We spoke about hepatotoxicity and agranulocytosis.
Oh, yes.
For both or for PTU only?
PTU is the main one.
So we have to
Monitoring.
avoid it in pregnancy.
We're going to speak about the pregnancy just a moment, please. Because one, you can give it in the first trimester, one, you cannot give it in the first trimester. So we're going to speak about it one moment.
Yes.
So hepatotoxicity and agranulocytosis. Monitoring. What you going to monitor?
Neutrophils.
BBC and LFTs.
Definitely. If any drug, you know the side effect of it, hepatic or hepatotoxicity and agranulocytosis. So what you going to monitor? Common sense. Yes. Yes. So liver toxicity, yes. Liver toxicity, maybe whatever it is, and CBCs and so on. Now we're speaking about methimazole. Methimazole is going to be number 1. You prefer it first line treatment if it's a routine hyperthyroidism.
Yes.
If it's any routine hyperthyroidism, you're going to start with methimazole. If we're speaking about life-threatening condition as thyroid storm, what is your answer?
PTU.
So it's PTU. If you think about thyrotoxicosis, it's excess of the thyroid hormone effect. What you can give? Methimazole, you can give it. If it's severe thyrotoxicosis with a systemic decompensation, Dr. Stephanie.
Yeah, I'm confused here. I thought, okay, I don't know.
Did you get it?
I got lost there. I thought we say PTU, but
PTU, we said it's for thyroid storm.
oh.
It's life-threatening condition.
Yes, yes.
If you have life-threatening condition or thyrotoxicosis plus systemic decompensation, your answer here is PTU.
But what would
If you have just thyrotoxicosis, you're going to go ahead and do methimazole.
Okay.
Did you get it?
Yes, I just got confused, I guess, because it was mentioned here, but yeah, I get the difference.
Yes, yes.
Can you repeat the life-threatening condition, thyrotoxicosis, severe, and what's the SD?
Say this again, please.
Like propylthiouracil we use in a life-threatening condition. Like
yes, yes.
The second one is severe thyrotoxicosis, and the third one is
systemic decompensation.
Systemic. It's severe thyrotoxicosis plus systemic decompensation.
Okay, thank
So
you.
you will
That's
basically
a thyroid
prefer,
storm.
yeah, you prefer to use your PTU in any condition or thyroid storm.
Yeah, thyroid storm.
Yes, yes. Otherwise, you like to start with the methimazole.
Mm-hmm.
So I think,
So
sorry, Dr. Abdul. I think the reason for that is also very simple. That PTU prevent the peripheral conversion of T3 to T4. So, and because it's an overwhelming emergency, so you would like to use PTU, which act fast, and
Yes.
then block peripheral conversion of T3 to T4. Then
yeah,
for the methimazole, I think it has to do with blockage of synthesis of thyroxine. So the onset of action is a bit slower compared to
Lower.
PTU.
Yes.
So you
Yes.
want to
yes.
deploy it when you want to treat thyrotoxicosis or hyperthyroidism, as the case may be.
Yeah. So remember that methimazole, write it down.
Mhm.
You use it in any or use it as a first line in a routine hyperthyroidism,
Yes.
Graves' disease, whatever it is. PTU is mainly used in two situations for your exam. First trimester pregnancy, because I know they won't wait for it, and thyroid storm. Oh my God, guys. So, thyroid storm and first trimester pregnancy. So,
Yeah.
okay. So, if it's a first trimester, you're going to give
PTU.
PTU. If it's a thyroid storm, you're going to give
PTU.
PTU. If the patient is, okay, if it's second or third trimester, methimazole.
Mm-hmm.
Dr. Murphy, are you the one who's asking about the pregnancy?
Yeah.
Did you get it now? Or you
Yeah,
wanted
I
me
got
to
it.
repeat it?
No. I got it. Thank you.
Okay. So, thyroid storm, what you going to do?
PTU.
Thyroid storm
PTU.
PTU.
Pregnant first trimester.
PTU.
Pregnant second trimester.
Methimazole.
Regular Graves.
Methimazole.
My appreciation to your gray matter.
Yes.
So, number 4. So, we spoke about number 1, it's supportive. We spoke about 3 things. ABCs, then?
IV fluid cooling blankets.
Thank you so much. Second one, beta blockers. We spoke about which drug?
Propranolol.
Yes, and we spoke about when we give it, for what we give it?
To reduce tremor, decrease BP agitation.
Tachycardia, tremor, and agitation. Yes.
Yes.
And then we spoke about what is the side effects of it?
Bradycardia.
Hypotension. And yes, what you gonna monitor?
Heart rate, blood pressure, and
And signs of HF.
heart failure.
Signs of HF. And then you're gonna think about yeah. Okay. So next one, number 3, we spoke about the medication. PTU. So PTU, if there is a very severe condition or it's a thyroid storm, yes. Methimazole in any other condition of hyperthyroidism. The next, number 4. What was number 4, guys?
Iodine.
Iodine. So when you're gonna give the iodine, that's what they love to ask you about. After 1 hour after you give the PTU. So you have the patient, you gave him or her PTU, you're gonna go and give them iodine after 1 hour. Do not give iodine before PTU or methimazole.
Okay.
Did you get it, guys?
Yes.
So it can worsen the synthesis, or if it's too early, that's why you don't give it too early. It worsens the hormone synthesis. That's why you don't prefer to give it early. But that's all about iodine. I need you to remember. 1 hour after you give your PTU or methimazole, and you don't give it early because it can give you bad effects. Number 5. What is number 5?
Steroid.
Glucocorticoid, yes. So which one you're going to use here?
Hydrocortisone.
Hydrocortisone or dexamethasone.
Dexamethasone.
Yes. When you're gonna avoid it?
Severe infection.
Immunocompromised.
If there is any contraindication is happening there, but in general, will you use it in this condition with a storm which is happening or with a severe presentation or no?
Yes, we will use it.
What is the side effects? What's happening to the glucose?
High.
It's a
Hyperglycemia.
hyperglycemia.
And if you are thinking about its immunosuppressant, what do you need to worry about?
Infection.
Infection. So what you're gonna think about, what you're gonna monitor with the patient with the glucose? Sorry, with the glucocorticoids.
Glucose.
Yeah, I said the answer.
She gave the answer.
You have no mercy, guys. So you're gonna monitor the glucose and the hemodynamics. So
Dr. Abdullah, when we avoid this, I missed that point.
you avoid it if there is any relative contraindication for the drug itself.
Okay.
So just in general, if there is any contraindication for the steroids use, do not use it. Otherwise, you are using it because it's not helping you just with this condition. It helps you to reduce the peripheral T4, T3 conversion. That's
What
why
are
we
the
use the
two-
steroids.
What are the two glucocorticoids? Hydrocortisone and the other one is?
Dexamethasone. Yes. And as usual,
Steroid reduces the conversion of T3 to T4 to T3,
peripheral.
right?
Yes.
Peripheral.
Yeah, the peripheral conversion. Yes.
Okay,
yes.
just like PTU.
Yes, it's also okay. If there is an adrenal insufficiency, what's gonna happen if you give a corticoid?
It will improve.
No, we need to
It's
give.
covering or it covers for you the possible relative adrenal insufficiency.
Yeah.
So it covers for you if there is any adrenal insufficiency.
Because there are no hormones, so that's why.
Yeah.
In insufficiency, there are no corticosteroids, so that's why it can
Yes.
cover.
Yes.
Okay.